Everyone, can you see my screen? Awesome. Oh, sorry about that. There we go. So thank you. I'm always happy to come visit with you all and be a part of this ECHO. So I appreciate the invite. So today I'm going to be talking about behavioral health equity through use of the CLAS standards. Just before we begin, again, I sort of do this work both in my Center for Pediatric Behavioral Health and our larger Pediatrics Institute. And one of the things that we are pushing is for more clear adoption of CLAS standards. So that's sort of the guise of where we're coming from today. So what we know in terms of the need for CLAS standards is that there is a significant gap in treatment when it comes to treatment need and then engagement for certain populations. So I'm just going to highlight a few and we'll talk a little bit about just how these are just a snapshot of some of the groups that are experiencing those behavioral health inequities. So for African Americans, we know that the difference between treatment need and treatment engagement and retention is significantly large. This graph just sort of depicts that. And so in terms of serious mental illness, co-occurring issues, or even depression, you see that the treatment need is much larger than the actual treatment reception or treatment engagement. We see the same sort of problem or pattern with our Hispanic and Latinx population as well. So again, you're seeing a significant portion of folks who are not in treatment despite having active treatment need. And again, this is just a snapshot. So while we're highlighting Black and African Americans, we're also highlighting Hispanics with these graphs, you'll see these graphs for other marginalized communities. So whether it's related to gender identity, sexual orientation, disability status, there are these similar patterns that emerge for these different marginalized communities. So just something to kind of keep in mind in terms of what we can do to bridge that gap. So what are some of the factors contributing to those gaps? Well, frankly, it can be one's background and previous experience. So if someone has had a previous mental health experience that was not a positive experience, that can preclude them from seeking services in the future. We know that for various minoritized and marginalized communities, we have structural barriers that impact their ability to access care. For some of our populations, there's also a paucity of bilingual or bicultural providers, and that increases sort of the barriers to care, a lack of linguistic competence of services, and a lack of cultural competence of services. Those last 2 points are important because I just want to sort of highlight is that one of the factors that really sort of contributes to these gaps is frankly discomfort with the mental health care system. And sometimes that is based on experience, sometimes that's just based on perception, but sometimes that is also just based on an inability for an agency or for a behavioral health care provider network to provide care in a way that meets the needs of the individual. So whether that's language accessibility or just not attending to or considering cultural factors can be the factors that contribute to that gap broadly. So the CLAS standards, which are the cultural and linguistically appropriate services in health and healthcare, were established to try and help bridge this gap. And they're meant to provide guidelines and a framework for agencies to provide services that are respectful and responsible or responsive to individuals' needs based on a variety of these factors. So again, at the very beginning of the presentation, we only highlighted sort of that treatment gap for Hispanic and Black populations, but you can see from this image, on all of those different domains of identity or social category, we can see those similar gaps. And those are things that we want to pay attention to in terms of making sure that we are providing services in a culturally responsive way. So the CLAS standards were developed with that in mind. So basically, the CLAS standards are broken up into these 4 different areas, with the principal standard sort of being the first one. The principal standard being to provide effective, equitable care and quality of care that is responsive to the diverse cultural health beliefs of a population or of an individual. So that's the principal standard. That's sort of the guiding principle or the guiding idea that then these other areas fall under. So what's great about the CLAS standards is it really asks you to think about cultural and linguistic competence, not just in terms of the delivery of care, so that direct patient care interaction, but all of the other aspects of an agency organization or an agency's processes that contribute, frankly, to that in healthcare encounter. So we're talking about governance, leadership, and workforce. So that's looking at an agency's leadership structure and their workforce membership, and looking at, do we have folks that represent some of the populations and communities that we're intending to serve? And if we don't have a population or don't have providers that look like the communities that they serve, how do we enhance that? So it's looking at issues of like recruitment and retention, also looking at just representation in the leadership structure itself, which we know is also very important, and also looking to educate, train, and provide additional support to leaders to be able to lead an agency that represents a diverse network of providers, which also serves the needs of a diverse patient population. It also really focuses on communication and language assistance as well. So when we think about language accessibility, it's not just necessarily, you know, do you provide interpretation services, but really looking at how do you address language accessibility issues throughout your organization, from when individuals call into your organization, from documents or from educational materials that you share. Where do we see some of those issues in terms of that language accessibility come to fruition, and how are we actively addressing it? And then in terms of engagement, continuous improvement, and accountability, some of the factors here that are highlighted are definitely partnering with the community. So really working with the community in terms of understanding the needs of the population and involving the community as almost shared decision makers in some of your work and initiatives. So where community members may serve on advisory boards, or where community members may have a larger say or a larger presence in your organization in terms of how they maybe help bridge, in some ways serve as cultural brokers for your communities and patient populations that maybe are more underserved. So those are some of the areas that are highlighted in this. But again, this is referring to your organization in totality and your organization as a whole. It takes us a step beyond cultural competence of an individual provider providing individual level care, but really looking at that provider in the context of a larger environment and the larger network. We know that things filter down, so we have to be able to improve cultural and linguistic competence as an agency more broadly in order for all of that to really filter down and filter through down to the individual provider level. Oh, sorry. And so we also sort of think about this in the context of the health improvement guidance. So basically this outlines that in really order to achieve health equity, we really have to move beyond just looking at individual factors, but really have to look at individual, institutional, and community level processes. So it really sees health equity or health inequity, frankly, as a system being responsible for that, but then also a system being responsible for essentially fixing that issue, right? So promoting equity. And it encourages agencies to really move beyond their walls. So not be limited by their walls and really try to impart sort of impact in the community by having and cultivating community partnerships to mitigate those inequities. So you might be asking sort of, okay, so I get it. We have this framework, we have this blueprint. Now, how do we actually implement it? So I'm just going to walk you through some of the things that we've done in the Center for Pediatric Behavioral Health to sort of help jumpstart some of this. So first and foremost, we basically are undertaking strategic planning around this. So before we do anything, we're sort of taking this step to kind of figure out where we are in the process, and then how do we implement strategies that are consistent with our goals when it comes to cultural linguistic competence. So this just sort of outlines what we've done. So we start with sort of identifying a mission and vision for this work. And the reason why that's important is because it really lends credibility to this being a hallmark or sort of a core component of what you're trying to accomplish, right? If it's written into your mission, if there's a mission around diversity in your organization, then that demonstrates a level of commitment that might not be there if there wasn't a mission statement potentially. So it communicates some intentionality to this effort. You also want to perform a current state analysis. So where are we in this process? So for us, that meant doing a baseline assessment of cultural competence of our providers, our staff, and our trainees. So you need to perform sort of that state analysis to understand where are your strengths, where are your weaknesses, where are your gaps. That also includes a SWOT analysis. So we also did a SWOT analysis to sort of look at, as we undertake these efforts, are there going to be things that potentially serve as barriers, serve as facilitators, things that maybe, cause some challenges along the way, so that we can basically proactively prepare for those and sort of keep those in mind in order to develop strategies that will allow us to potentially bypass some of those barriers or overcome those barriers. Then we identify strategic priorities and activities that are in line with the CLAS standards. So again, we're now identifying, okay, what are our key priorities and what are the strategies that we're going to implement in order to meet those goals or meet those objectives, with the CLAS standards sort of being the overarching guiding document, if you will. And then we identify and prioritize those activities. So we could undertake a multitude of things, but obviously, we are limited in terms of our manpower, our resources, and our budget. So we have to prioritize what are the things that may be most important. What are the things that we want to tackle, as a first priority when it comes to class standards? What are the things that maybe will help turn the wheel, will help sort of keep the ball rolling, if you will? What are some of those activities to undertake first, which then will sort of allow us to continue and sustain the work moving forward? And then how do we measure our achievements and adjust if needed? So this is just sort of the, framework to try and implement some of these things. And so, what we've done, again, is a baseline assessment of the implementation of the class standards. We're trying to emphasize data-driven decision-making regarding improvements in implementation of class. And then we've done the strategic planning for class-related activities. So we held a strategic planning session in order to really devote time. We did it on a weekend, but we really did it to devote time to discussing these issues, identifying, doing the SWOT analysis, identifying our barriers, our facilitators, and really coming up with a living document that serves as our plan for this space. Part of that, it means we're going to be providing ongoing and continuous training of class standards, outline class-related considerations for training and development, and then again, work with different community healthcare partners for ongoing feedback on our efforts. So we don't want to do this sort of in a siloed way. We want to make sure that not only are we, being honest with ourselves in terms of our work, but we're also getting feedback from the community or feedback from some of our key stakeholders regarding our work. Are we on the right track? Are we making the improvements that we intend to make? Are we having the impact that we're intending to make? Which can sometimes feel for us like, yeah, we're doing a good thing. We're plugging away and we're doing good work, but maybe from the community standpoint, they're not seeing the benefit of that, or they're not seeing, what we're internally working on. So really looking at trying to involve community stakeholders in our processes as well. So again, this is just sort of that process. And then this is sort of an example of a SWOT analysis. So I'm just going to go through some of the things that came up when we did ours, just briefly. So, in terms of strengths, what were we able to build on when we did this work a bit ago? We built on strengths that we identified included our leadership being interested in this work, that we had some leadership buy-in, that we had a national discourse that was also supportive of these efforts, that we were in line with some of the other movements being done across our enterprise here at Cleveland Clinic. What were some of our weaknesses? Again, for our center, weaknesses were historically that there hadn't been a lot of work done in our center prior to this undertaking. So we didn't really have a track record necessarily for having done this work. So that's a weakness, right? We're sort of starting from scratch. Opportunities, we leverage sort of our different partners in terms of different areas within our enterprise that we identified as also being engaged in this work. And so how could we leverage their resources? How could we partner to sort of help amplify the message and identify more opportunities for collaboration there? And then what were some threats? So, honestly, threats were, lack of historical inaction. So, people not being interested in this work in the past, perception that, we had a status quo where people were comfortable with the status quo and weren't interested in changing it in any kind of way, that there would be some resistance to some of this work. And threats were, time, resources, demand on folks. So a lot of the folks who are doing this work are a committee, but are a committee who, at least at the beginning, were a committee that didn't have any time necessarily allocated to this work. And so that's a threat, right, to the sustainability. We all are very busy individuals. We all have a lot on our plate. And historically, DEI work, cultural competence work tended to be things that were add-ons for a lot of individuals. The perception of that is changing, where we're trying to ensure that people have, that this is a valued contribution to an agency. So people are getting credit or receiving some sort of resource or some sort of recognition to be able to do this in a way that doesn't feel like it's an additional burden. But that is something that we did consider as a threat at the very beginning, and I'm sure serves as a threat for a lot of entities trying to engage in this work. So in terms of assessments, here are just some sample assessments. So this is one that is available from the National Center for Cultural Competence at Georgetown University. I think I've mentioned this organization before when I've done presentations for you all before, but they have a wealth of resources. And again, they're not behind a paywall, so they're available to the public, very easily utilized. They're very easy to understand and easy to utilize and implement. And they just have a lot of different resources. So this is an example of an organizational assessment. And you can see from the sample questions, one of those is looking at the diversity of the families, the diversity of the organization, and how often does an organization engage in maybe some of these ongoing in-service or training opportunities. So this just sort of gives you a starting place, because again, to make improvements, we have to sort of know where we are, and where we are at the very beginning in terms of our gaps and areas that we need to improve upon will then help inform your strategic planning, or help form those goals that you want to be working towards. This is an example of a self-assessment. So this is actually the assessment that we administer to all of our staff and trainees here at our Center for Pediatric Behavioral Health. Not everyone necessarily responded. It was voluntary, so whoever wanted to respond, but we encourage participation from everyone. But this was a good sort of starting place, because it, again, gave us areas to identify where our weaknesses were and areas that we wanted to improve upon. And for some, just even taking the survey, a lot of the feedback from individuals themselves to me was, that question or that item really made me think. I didn't even think about that necessarily. I didn't even think about what was in my room, what were the messages or subtle messages that maybe I was sending without having lack of representation in my artwork, or, in my play materials for, therapy with children. So really starting to just identify and open up some eyes into maybe what are some areas that potentially could be easy areas for intervention or easy areas for change. And then again, working towards those maybe harder things to accomplish change. So you sort of identified some low-hanging fruit, and then some other goals and objectives that would obviously take a little bit more time to pursue. So this is another tool for cultural competence, but this is for anyone who may be working with other partners in terms of like having a community coalition or community collaborative that's working towards any shared goals. This just looks at the cultural competence of that coalition, if you will. And so that's also important to work on or assess when you're working with community organizations, because when you work in a collaborative or work in a coalition, you have varied organizations represented at the table, and they themselves bring their own culture to the table. And so really looking at examining cultural competence in line with making those coalitions and collaborations more effective, even strengthening the capacity for those coalitions. And so there are some resources that I want to make sure that I share with you. So one is the minority health standards themselves. So it's just a PDF of the standards that we've talked about today. And then there's also a cultural health online module. So the second link is literally to an e-learning series from the Office of Minority Health that provides training on cultural competence and using sort of the CLAS standards. And they also have a blueprint specifically on how do you implement some of these activities in behavioral health, because one of the things is that the CLAS standards were for health and healthcare. And one of the points of feedback has been, this doesn't really fit necessarily behavioral health the way maybe it does fit traditional healthcare or medical care. So that's been some feedback they received for like community mental health organizations, or maybe other organizations that are smaller in stature. And so, compared to like a hospital, it maybe for them, it didn't feel like it resonated as well. So they actually created a blueprint for how to really adopt some of these strategies for behavioral health as well. And again, this is not a framework that states from the beginning you have to implement all of these strategies or all of these sample strategies, but rather gives organizations something to think about, gives them a framework to work from. Because one of the biggest barriers to this work has been, from my experience, has been, we really care about this work, but we don't know where to start. This just feels really overwhelming. And so the CLAS standards gives you a framework. And then from there, you're sort of able to carve out what pieces of it are applicable to your agency and what pieces of it may be things that you want to really, again, prioritize in terms of your work. So I just wanted folks to make sure that they knew like this resource existed. There are ways, there's even a blueprint on how to apply this to behavioral health. And there are e-learning modules as well on board for being able to become more integrated with this information and see how it can integrate into your agency as well. So I just wanted to kind of cover the basics, and I know I'm trying to stay to my required time, because I know in the past I've gone way over my required time. So I wanted to try and keep this a little bit short. So I do have references here for you, including references and links to those organizational assessments and the self-assessments that I included in the presentation. So you have that as well. And then I think that's it. So